in the past few days, there has been an increase in the views of my Nursing is Toxic video. And I've been getting a lot of comments on that video. For those of you who have followed me for some time, I made that video last year after I had an experience working on the ICU. I went in for a night shift. Who told me pick up that night shift? But anyway, I went in for a night shift and I was told, hey, we're giving you this nurse to train. And I'm like, okay, cool. I always welcome taking on a nurse because I like training. By nature, I am a teacher. I have a master's degree in nursing education. I love academia. I love the process of education. I love seeing the connection. I like seeing the light bulb go off, the imaginary light bulb go off in a person that's learning brain. I enjoy that whole thing. It gives me all the joy. So when they said to me, here, we're going to give you this nurse to train. She's not a new nurse, but she's new to the ICU. Let's go. So I made a video basically chronicling the incident that happened with her telling me that her preceptor, her original nurse training person, because for some reason, some of y'all don't like in the comments when I use the word preceptor or orientee. Someone was like, why you got to keep using that word? Ma'am, that's what we call it. Okay. That is just what we call when we're training a new nurse. We're precepting them. I'm the preceptor. She's my preceptee. Okay. So just to clarify that. But I found out throughout the shift that her preceptor, her original preceptor, which wasn't me, was not pretty much being nice to her, was not training her in a manner that was conducive with learning and welcoming, so on and so forth. So I talked about the issue, and part of me discussing the issue, I brought up the issue of race. And that bothered a lot of people who let me know in the comments, I was with you until you got to the issue of race. Now, let me ask y'all a question. I am a black person. I am a black woman living in America. How am I not going to talk about race? Like, how? Some people in the comments were like, well, it didn't have to be about race. It could be about women just being toxic in the nursing field, just being women, or maybe they felt like she wasn't doing things. Maybe she wasn't up to par. And I'm here to say that multiple things can exist at the same time. Trust and believe, before I jump on the race factor, I would have sat and considered all of the different aspects before I made such an assumption or an insinuation, right? So I had her with me for the night. Before the shift even starts, I establish an agreement with the person I'm training, like, hey, these are the boundaries. This is what you're going to do. If you need any help, you let me know. For this nurse, she had 3 years of nursing experience on an intermediate care unit in an urban setting. Okay, so the difference is when you're working in an urban setting or in a really rural setting, trust me, you're getting what you need. So I was like, all right, cool. And you work at that hospital. You worked at that other hospital. That other hospital uses the same charting system as we're using right here. So we good. How long have you been on orientation? 6 weeks. All right, we straight. You should only need me. You should be able to let me know when you need me. Of course, I'm going to be watching. I'm going to be, every now and then checking her documentation just as a reminder. Don't forget this. Don't forget that. Or good job on this. Good job on that. When we first went into the room, because at the time when the shift started, we only had one patient. The patient was very sick. Just came from the operating room. Status post XLAP. I think the patient had a bowel obstruction. So he had a new ostomy. He was COVID positive. He was sedated, on a ventilator, A-line. His blood pressure was low. It was just like a bunch of stuff going on. He was on a bunch of presses. It was just like, and plus, culturally, the patient was also Muslim. So we have to take in the cultural factor, like with the families and so on and so forth, visitation because of COVID. It was just a whole mess. We went into the patient's room. And the reason why I go in initially is to kind of watch that nurse, how they're going to start their shift. What do they do when they first go into the room? When I went into the room with her, the first thing she did was open up the computer system. All right, cool. She looked at the Foley. Okay, good. You're checking for intake and output. All right, you good. She came, lifted up the patient's gown. Why? She wanted to eyeball the new ostomy. Checking the stoma, making sure it's pink, making sure it's not necrotic, it's not black, because if it is, it's a medical emergency. Then she said to me, the only thing I think I'm confused about here is the drips and the A line. The patient had an A line to measure the arterial pressure. It gives us more accurate readings on blood pressure. Plus, it also allows for like the respiratory therapist or even us as nurses to draw ABGs if we need to. So she said, yeah, I don't really know how to zero it. She's like, they taught me, but I just need a refresher. Bam, I went over it with her. For the pressors, on my badge, I have a card that gives me the range, the parameters on when to go up and when to come down on specific pressors, on specific sedation. I have all that information with me. So I asked her, I was like, you don't have one of these little badge? She was like, no one ever gave it to me. First of all, wait a minute. So you've been on orientation for 6 weeks and no one taught to give you a badge, a clip thingy for your badge, so you can know if your patient is on 3 different presses, 2 sedatives, you kind of have an idea, like a reference, just to kind of flip and see in case you need to go up or come down, depending on the blood pressure, depending on the maps. Like, you don't have that? She was like, no. So I gave her mine, right? I gave her mine. So she was like, thank you, or whatever the case is. So she went about, she pulled out her the patient was in isolation. So she used the isolation stethoscope. She started listening, whatever. She checked the ET tube. So I was like, oh, girl, you good. I'll be sitting right out here, okay? Tap that window if you need me. You have your Vocera. I'll check in on you as well, but just know I'm right here. And she was like, good, I got you. So at that point, I had established trust with her. Throughout the entire shift, she did very, very well. I was impressed. And like I said earlier, multiple things can exist at the same time. So I'm like, okay, she knows what's going on, so I don't have any reason to be concerned. She's documenting in a timely manner. She knows the document. She knows the charting system. All right, so we good. When her preceptor came to me and asked me how she was doing and had all of these negative things to say, the only thing I was left to work with was the race factor. And the reason why is because we are not going to sit up here and pretend that nursing does not have a history of racism. We're not going to pretend that the American Nurses Association did not put out an apology memorandum, a year ago, 2 years ago, apologizing for the racism that occurred in nursing historically and for the racism that continues to occur today. We're not going to pretend like those things didn't happen. So the fact that a lot of you were bothered by me bringing race into the equation, too bad. So sad. I'm not sorry, because I had already analyzed the fact that, okay, she's good. She knows she has good assessment skills. She understands the flow of assessment. Her charting was good. She understood documentation. She knew what needed to chart. She also asked for clarification. As a nurse, asking for clarification is very important when you don't understand something. When we first went into the room and she told me she wasn't clear about the A line, she asked me about it. You know why she was comfortable asking me? Because there were no barriers. A person cannot learn from another person when they're afraid of them. So the first thing I like to do whenever I'm training someone or whenever I have a group of nursing students is eliminate the fear barrier. Because if you're afraid of me, you're not going to ask me and you can't learn from me. And the fact that she was honest to say, hey, I need clarification on the A line. And hey, I'm not too sure about the drips because she was like, it's a lot of them, and I kind of have an idea, but I'm not 100% sure, so I'm going to need you for that. She let me know out the gate, hey, this is what I don't know. So I was able to establish trust with her and tell that, you know what, this is a good nurse. This is a nurse that's going to be able to say, hey, this is what I need, this is what I don't need. No, I'm comfortable doing this. So when her preceptor came and said she was having issues with her, I was like, no, it's something more. And we all know, or some of y'all can pretend like y'all don't know, or if you don't know, for real, historically, and even, I would like to think it's improved these days though since COVID, but historically, and even when I came into nursing, most intensive care units were all white. Predominantly white nurses make up the ICU. And if you go on night shift, you might find some Filipinos, you might find the one token black nurse. But for the most part, ICUs have been predominantly white. Nursing is predominantly white. Nursing is known to be the white woman's profession. Like, I'm not making these things up. Like, it's facts. And to be honest with you, well, you know what? I shouldn't have done nothing because I ain't got time, okay? I got to maintain this place. I have my daughters. I'm in school, and I work 2 jobs. I ain't got time to do no extra research for y'all. The information is out there. You got Google. If you truly want to learn, you can Google it and find out. But historically, nursing has not been kind to Black women. And I'm specifically speaking on Black women because that is the only experience I can speak from and speak of. I know some of the people in the comments were like, well, I'm a Latina or I'm an Asian nurse and this happened to me. Listen, I'm not doubting that, but I can't speak to your experience. I can only speak for me and the people that look like me, okay? So we're not going to sit here and pretend like nursing did not have a racist history. And specifically when it comes to ICU nursing, ICU is seen as the creme de la creme. To get into the ICU, it's a big deal. Someone even was doubting me in the comments when I said, I went to an HBCU. And we were told by our nursing professors, not once, not twice. Anybody from Coppin State University in the comments, vouch for me, please. If you graduated 2010, vouch for me, please. We were told it is going to be difficult for you all to enter into the ICU because ICU has a specific look. ICU is known to have an aesthetic, the white girl aesthetic, the white woman aesthetic. That's facts. The problem is with a lot of y'all with this kind of conversation is the guilt. Absolve yourself from the guilt. We know that you didn't create the system. You present day today, you didn't create the system. We know that. But that doesn't mean we can't talk about it. That doesn't mean the system never existed or doesn't still exist. The issue is being held accountable. The issue is pointing it out when you see it, calling your people on it and saying, hey, why are things this way? Because if I am working in a hospital that's diverse, that has a diverse surrounding, and I'm in a specific unit where everybody's one color and the other people in these other units are that color, as a human being, it's going to trigger some kind of curiosity in my mind. Like, so what's really going on here? Like, is this like, you got to be white to work here? Like no one else works here and the only people of color or the only minorities are the Filipinos on night shift? Is that what it is? In the comments also, there were people doubting the things that I was saying. And I'm like, I'm not the only Black nurse on here telling y'all that this happens. Other Black nurses have made videos talking about their experience working in the ICU and working in critical care and how they were treated. And it's not only specific to the ICU, but it also happens in other units that are seen as creme de la creme units. For example, NICU, which is the neonatal intensive care unit, and also mother baby, because mother baby, honey, the nurses do not leave, okay? The girls get hired at 23 and they retire at 62 because that's pretty much an easy job. Like it's nothing really on your back. I mean, every once in a while, or maybe current times, the mother baby patients are more sick. Labor and delivery have their set of issues as well, to where Black nurses feel ostracized or they're not really welcomed into those specialty areas. What I'm saying is not new. And what I'm saying is not made up just based on that one experience, okay? Multiple nurses have had this experience. We've shared it. And a lot of y'all still want to doubt it. Why? Now listen. If I had that nurse and she displayed to me or showed me that she was not ICU ready, honey, trust and believe I would have spoke up the same way. Because my thing is, just because I'm Black and you're Black doesn't mean that I'm going to give you a pass to be here. If I don't think that you're safe for the patient population that we care for, I would have reported it as well. Like, listen, she's not up to standards, okay? She probably needs to go down to med surg. She probably needs to go to telemetry. She probably needs to go to IMC to get her basic foundation. And then maybe in a year, she can reattempt to come again. Because being a new nurse in the ICU is not easy. And that's the reason why, for me, I am one of the nurses who feel like there is nothing wrong with starting off in med surg. There is nothing wrong with going to a step-down unit and learning your core skills, learning how to manage, learning how to prioritize, knowing the hospital culture, knowing the charting system, because what kills a lot of them is the freaking charting. Because we have to document so much. That by the time you're overwhelmed with the documentation, your patient's crashing, the other patient got to go for a follow-up CT, and you're just like, that can burn you out as a new nurse. It can be a lot. On top of the fact that they making you do rotating shifts. Nah. So if I had found her to be not up to par, I would have spoke up in the same manner. But she was up to par. And I was also familiar with the fact that the person that was precepting her, like there's a crew of them. It wasn't just her. It's a crew of them that's on night shift that everybody knew. Everybody knows that if you don't fit a certain aesthetic to be part of their crew, they be talking about you. They'll ostracize you, and then word gets back to the manager. And a month later, I'll be looking for this new grad nurse or this new nurse. Like, oh, what happened to such and such? Oh, yeah, we had to downgrade her to, the unit downstairs because she just wasn't, she just wasn't getting it. What y'all mean she just wasn't getting it? Like, what does that mean? Half of the times, they don't even have legitimate reasons. They don't even have weekly check-ins as to why this nurse was not meeting criteria. Like, it's just usually based on word of mouth by the people who are deemed popular, by the people who deem like, yeah, we this, we that, da-da-da-da-da, like by the people who have 8 months of nursing experience, only 8 months, by you out here trying to run to take care of the sickest patients. Like, calm down. Calm down. A lot of times they're the ones running back to the manager, telling the manager things like, oh, this person's not equipped. Oh, this person shouldn't be this. Girl, you just got out of school yesterday. Calm down. Calm down. Now back to the issue of race. I had my own experience with a specific recruiter and a specific nurse manager. And I told my story in the 3-part series that I have. It's not a series. It's a 3-part story I told of the time when I applied to ICU and they tried to play me. And you know what's so funny? I told in the 3rd part, when I finally got back into that ICU, into the float pool, and I went on the unit, the nurse manager, she couldn't look at me. And then a couple months later, they forced her to resign. They marched her right out of her office, had her pack up all her stuff, and security escorted her out the building. Guess who I saw the other day? Her. Yes, child. Went for my competency, and I had to go get fit tested. And who was sitting in the room? The lady who was checking us in asked me, what is your name? And when I recognized that, former ICU nurse manager was sitting over there. I think she was there to help administer flu shots and help with fit testing. So when the lady checking us in was like, what's your name? I said loud and proud, Kendra Isaac. What unit do you work? Critical care flex pool, specialty flex. She couldn't even look over because she knew what she did. And another thing I'm going to share with you guys before I end this video right here, because I don't want to keep ranting on and on and on. When I applied for the ICU back in 2014, I think it was, there was a specific recruiter. That recruiter, dangerous lady. That lady was dangerous. Because even after she left, the recruiter left that hospital, she went to another hospital. And remember, I was a nursing instructor. And my students would apply for jobs at that large academic teaching hospital, one of the largest hospitals within the United States that's known for all their, innovative, for their research. We know that hospital. My students would apply to that hospital, and that recruiter worked at that hospital, and she would get my students' applications. And let me tell you what she did to one of my students. I gave my students a recommendation. Cool. The recruiter tells her that she needs another reference. And the girl was like, well, I gave you all the references you asked for from all the jobs that I had. The recruiter was asking her for a job that she did when she was 18 years old. And the recruiter wanted a reference from that job. Girl, stop playing. I was like, are you serious? Such and such is asking you for what? She was like, yes, she want me to find that store that I worked at that no longer even exists. You know what? I really wish I remember the exact dates. I don't think it was exactly 1995. So this was back in 2015, 2016, right? One of my students had a job when she was in high school. So she had to have had that job in the early 2000s, 2003, 2004, maybe. But the recruiter was asking her for a reference from that job, saying that, you might not be able to start, or we might not be able to hire you if you can't provide this reference. And the student called me because she had already passed her NCLEX. She had graduated she already graduated nursing school. And this same recruiter that I knew that worked at my other hospital was trying to give her hell. And I had to intervene. I personally emailed the recruiter, and I told her, you're being ridiculous. In so many words, you're being ridiculous. She worked at that job when she was like 17. The store no longer exists, ma'am. She has graduated with 1 degree previously, and now she got a 2nd degree, a nursing degree. And she provided you all of the references. She provided you recommendations from her clinical instructors, and you're here asking her for a reference from a job that she worked at when she was a teenager? Are you mad? I sent her an email, and guess what my student told me? Oh, she called me back and was like, oh, never mind, disregard the reference, whatever. She submitted everything, and I'm going to be able to start orientation. You know why? Because I had told her in that email, I was like, if you continue to do this, I'm going to alert the people on top of you. I'm going to notify your boss. You know the reason why I knew who her boss was at that institution? I was a clinical instructor. No, I was teaching at the time RN to BSN students. And a lot of hospitals, to help their RN students get their bachelor's degree, they would host the universities on campus. So this one specific university had partnered with the hospital, and I was teaching for that university. So I used to have to go on the hospital campus to teach that class. And it was right near where the human resources director was. Because the human resources director, whenever I got there at like 5:30, because class started at 6, the director would be the one to remind me to shut off the overhead, the projector. She'd be like, oh, don't forget to turn the projector off because we can't afford for the light bulb. The light bulb is very expensive if it dies. So that's how I knew the human resources director. You see how God kind of put people in places? Like, you just never know the connections. So when she was giving my student a hard time, I emailed her and I let her know, if you continue to do this, because I know what you're doing, I'm going to notify such and such, because I knew the lady's name. That's the same lady that would tell me turn the projector light off. She didn't know I knew that lady. She didn't know I was a professor at the time for the RN to BSN students at her facility. She didn't know that. I hope I ain't confuse y'all. But yeah, a lot of games get played, and that's the reason why I like that we have to shed light on these issues. And for the white people, y'all need to stop feeling guilty. Stop feeling guilty. For the white nurses, if you're working in an ICU unit in an urban setting and your patients are predominantly black, and you don't have any black nurses working on your ICU, that should ring a bell in your mind. Ask your manager, why isn't the unit more diverse? Why don't we have a diverse group of nurses? Why is it only us? Why is it only people that look like me and then a few Filipinos on night shift? Ask questions. Ask questions. That is the only way we can come to a mutual point and say we're all working together. But no, some of y'all don't want to ask. And when we tell our stories, well, maybe it was this. Oh, well, maybe she wasn't catching on. No, ma'am. No. And we must also not forget that every human being has bias. We all have biases, right? And some of the biases that we have can be subconscious. Some of the biases that we have, we learn it. We learn it. We hear things from our parents. We hear things from our grandparents, our uncles, our aunts. So sometimes you come into a situation and you're thinking, so you graduated with your BSN too? Yeah, I got my BSN. Oh, and you have a master's in nursing too? Wow, yeah, I do have a master's in nursing. Like, how did you get that? Same way you did. I went to school. Let's not pretend, okay? Anyway, I have an exam to go study for. I shouldn't even be on here running my mouth the way I just did. I just wanted to come on because I saw that the video was taken off again, and I just wanted to put my 2 cents in. And I'll catch you guys in another video.